Good morning, everybody. It's about 10:30. Good morning from Perth. My name is John Blakey. I hope you can hear me now after some technical difficulties earlier on. This Facebook Live on behalf of Asthma Australia is to talk about acute asthma, asthma attacks, asthma exacerbations, those kinds of problems, and particularly in the context of the novel coronavirus. So today we're going to be talking about the following topics. Are you at risk of having asthma attacks, and how do you gauge the risk? What to do if you're having an acute asthma attack? What happens in hospital and how that might have changed recently? And a little about what we can do to reduce our risks of future asthma attacks. So my name is John Blakey. As I said, I work as a respiratory physician at Sir Charles Gardner Hospital in Perth. And about 18 months ago, I moved to Australia. After previously working in the UK for many years as an asthma physician, doing tertiary asthma care, and also at the same time some community asthma clinics. So while people are perhaps thinking about ways that they want to contribute and ask questions, I thought it was worth us taking a step back and having a think about asthma attacks generally. In the past, we've thought a lot about people's symptoms, how they feel with their asthma. And one of the things that's perhaps been neglected is the risk of having an asthma attack in the future. We know that asthma attacks are very common and also potentially very, very serious. The key thing about the asthma attacks that most people experience is that they're preventable. So we know that about 90% of asthma attacks are preventable with the medicines and the other treatments that we have at the moment. Excuse me. What we haven't had in the past really is a clear focus on addressing that as well as people's symptoms. And so over the last few years, we've been thinking a little bit more about how we can get on top of those things that people might not feel on a day-to-day basis, such as inflammation in the lungs, but will increase their risk of ending up in hospital or ending up at a GP surgery. There are some now asthma risk checkers available, so you can assess your own risk of coming into the GP surgery or hospital in the future, and think about those modifiable risk factors that we can all do something about. Those modifiable risk factors include things like having uncontrolled allergic rhinitis and hay fever, or being overweight, or perhaps not taking all of the prescribed doses of preventer that somebody normally would. So I think that's thinking about people's future risk is a good way of engaging with healthcare providers, saying, how can we reduce my risk of coming into hospital? How can I avoid being sort of those 1 in 16 people with asthma who's going to have a serious attack in the next 12 months? And the reason that's important is not just because of the physical unpleasantness of having the asthma attack, but also that asthma attacks do damage to people's lungs. So somebody who has a bad asthma attack every year, their lung function goes down at about the same rate as somebody who smokes 20 cigarettes a day. So people are accruing long-term lung damage. So as we sort of develop these risk tools, I think that's going to be an important way of engaging with GPs, particularly not just saying, how do you feel today, but also what can I do to reduce my risk in the future? Perhaps I feel okay today, but maybe I need to alter my treatment to reduce that risk, in the same way that people might take a cholesterol lowering drug or a blood pressure drug to reduce their risk of having a heart attack or a stroke. So at that point, I've been talking for a couple of minutes. If anybody has any questions or comments about thinking about that idea of future risk, please do pop me a comment and we'll respond to those directly. I see that Judy's contributed that she uses her Ventolin every day. I think so. She also uses, I think, Brio as a preventer. So it's important to take the preventer every day. So people who take less than 8 out of 10 of their prescribed doses, they do worse than people who take all 10 out of 10 of prescribed doses of preventer. Unfortunately, only about a third of people in Australia are taking their preventative treatment regularly, or looking at the pharmacy data that we get back. So there are quite a lot of people out there who are taking perhaps their reliever inhalers more frequently, and their preventers not quite so frequently. And that's something that we can do something about in the short term to provide some long-term protection. We know that people who use their blue inhalers frequently are at higher risk of having asthma attacks. So people who are having 9 Ventolins or Asthmols or something a year, they'd be at higher risk of having asthma attacks in the future. And that should be a trigger to talk to your GP or your hospital doctor and say, I'm using too much of this, what more can be done? In terms of the next steps of that, I think it's also about formulating a clear written plan. I'm sure many of you have got asthma action plans that say, when my symptoms are like this, then I should do this thing. Or when my peak flows are like that, I should do this thing. And I think that's essential for everybody to have. It's certainly in all of the national and international guidelines. And in trials, it's been shown to reduce people's risk of coming to hospital. And that should form part of a wider discussion around the things that you can modify. In terms of the sort of the next phase of things about when to seek help, one of the core things about that is if you have symptoms that are persistent, and particularly if you're not getting a good response from your short-acting drugs, the Ventolins, Asthmols, that kind of thing. If you're taking them and they're not really helping very much, that should be a trigger to see somebody. We see that when people get worse, there's variation, their lung function gets less, and they're drifting towards needing some assistance with a different kind of drug. The inflammation around the airway wall isn't going to get better with something like salbutamol. It needs something like a steroid or an antibiotic to improve. So somebody's raised a question about the future risk of a child going back to school. And it's a fairly typical story that children and younger people generally can be very, very well between asthma attacks, playing sports, doing normal stuff. But when they get wheezy, they get profoundly unwell. That's partially because kids and younger people can cope with their airways narrowing down a little bit. So when they have mild disease, they often can still do all the stuff that everybody else does. But when they do get that very vigorous amount of narrowing of the airways and the inflammation in the air tubes, it does need prompt treatment. As I've said before, there are things that we can think about in relation to that. One of them is the actual inflammation in the lungs themselves. Like we said, it can sometimes be difficult for people to feel what's going on in their chests. And so measuring that with things like peak flow monitoring or exhaled nitric oxide tests, and the things that are available routinely in hospitals now, can give us an idea beyond just what people's symptoms are. There was a large study a few years ago that asked children to guess what their peak flow was, and they were wildly inaccurate. They're not very good at appreciating what's going on in their chests. So we always should be pretty cautious and try and gather information as much as possible to help them. So if your child is at school and is feeling breathless and wheezy, it's important to intervene at an early stage. And so if the school nurse should be able to have a peak flow meter and should be able to assess the symptoms of asthma and give that first aid. And it's always better to be on the safe side. It's always safer to give people an extra few puffs of a short-acting beta agonist or get them to engage with a medical service at an early stage. And if everything's okay, well, there's no harm done there. But we don't want excess delays on that front. Yeah, so the Asthma Australia guys have just raised the thing we were saying before about frequent use of a reliever being a sign of poorly controlled asthma. And I guess that brings me to another point, which is most people with asthma are pretty accepting of the fact that they haven't got good symptom control. So when we go out and ask people about their asthma, most people say, oh, I'm getting on okay. And then if they're shown the guidelines about how good asthma control should be, then they suddenly reassess that and say, actually, I could be better than I am at the moment. So I think that's another thing to think about is, are you doing okay, and could you be better? And should we strive to being a bit better rather than perhaps, avoiding going for a bike ride or something like that because it might set you off? The other thing to think about is, as well as just sort of using your blue inhaler more often, is also anything that's unusual that's come along with your asthma symptoms. So, for example, if you don't normally have a cough and you have one, or you don't normally have chest pains and you're starting to get them, you don't normally have phlegm and it's starting to come along, those are the sorts of things that we want to know about and we want to check you out, because asthma is a big umbrella of different things. It's not one disease. So people have different kinds of asthma, and the type of asthma changes over time. So if you start to have something that's not quite right for you, again, that's something that should be taken seriously. It might be normal for somebody else, but not normal for you, and that's something that we need to flag up. In terms of where to go to get help, in terms of if your asthma is getting worse, obviously the first port of call for most people will be their GP. What we would not usually recommend is people having rescue packs of steroid tablets at home. That tends to mean that people stay home for longer and can get quite sick before they present to services, and it's usually safer to consult somebody. If you do see your GP because you're worse and you get a course of prednisolone tablets or antibiotics or both, the important thing at that stage is also to arrange some kind of follow-up, because we do see a large number of people who get treated and then don't get fully better. And even if they have got fully better, there needs to be some kind of follow-up saying, okay, well, why did that happen? How can we stop it happening again? That's particularly the case if you've been ill enough to go to the emergency department. So I understand that our emergency department colleagues are under a lot of pressure, and if they give you some acute treatment, that you might well get a lot better in the short term. But it's really important that there's some follow-up arranged soon afterwards, either with your GP or with the hospital asthma clinic. We don't want people sustaining that lung damage. We don't want people sustaining that probably anxiety and worry about having come to the emergency department. In terms of coming to the emergency, I know that a lot of people at the moment are concerned because of the novel coronavirus about coming to emergency departments. What I want to emphasize today is that we're open for business. We've been pretty lucky in Australia that we've had a very slow evolution of the number of cases, which means we've had a lot of time to plan and design services. So people who come in who may have the virus are very clearly isolated and seen by different doctors in a different part of departments than people who don't come in with those problems. So there's not going to be a high risk of picking up things from other people. So for example, in our hospital, we have two completely different respiratory teams on different wards seeing these individuals, and they're very clearly isolated in their own rooms and so on. So if you are unwell, please come see us. We are pretty well set up for that, and that includes outpatients as well. We've renovated the outpatients here, as I'm sure many people have come to solutions, including even things like redirecting air conditioning, so there's no risk of passage between rooms. If you ever come to the emergency department, the other thing that will have changed probably from what you're used to is being given airway opening drugs, the bronchodilators, with an inhaler and a spacer. So this is pretty routine practice in North America and other places, but I realize that in Australia it's been usual for people to have nebulizers. For people who we are not sure whether their nebulizers may spread any virus that they have because they're aerosol generating, we try and restrict the use of the nebulizers as much as possible. That's not to say that we won't be using them ever, but across the country, the first port of call will be to use several puffs of a reliever through a spacer in a safe environment where people are monitored. And if they do need a nebulizer, they might be put into a side room or somewhere else where they can be kept a little further away from the other patients until the tests come back. That kind of change in the way we practice can be a little bit concerning for some people. Being put away in a side room when you feel breathless can feel like people are not keeping an eye on you. So really, I just wanted to reassure everybody that we're well aware that kind of thing happens, and that we're really keen to be upfront about that, saying this is a temporary measure while tests come back. most tests come back within a few hours, and then you'll be back into sort of the normal circulation of being able to see people. If people do get admitted to the hospital and they are in a side room, I can understand that can be quite worrisome and quite stressful for people, because you're away from the healthcare professionals, their gowns and masks and things, and you can't see their faces. And visiting in most hospitals down to an hour or so a day. So I would suggest to people to have a chat with their healthcare professionals about how can they sort of soften that problem. So, for example, we have some of our patients on the ward having FaceTime conversations with us while we're outside, and then we can get a bit of a feel for how they are, and they can see what we look like before going in looking like we're just about to operate on them. In terms of the other things about being unwell, when people go home as well, I understand that there's or have been to the emergency department, there's going to be some concern around their symptoms, and the concern in the population about people coughing and being wheezy and breathless around other people. I think, as I said before, it's important just to be upfront with people about that and sort of approach that. I think there's always going to be people in the community who are pretty who are going to be pretty suspicious of that, and I think it's just something that will become less of an issue as we get slowly back towards normal and we approach coronavirus a bit more like we approach flu or something like that. So we've had a comment from Sharon there. So they say asthma is worse in cold air. So that's really common that people get cold air worsening of their asthma, and that happens for two reasons. The first reason is that if the airways are cold, or if they're dry, then they're much likely to have inflammation, and particularly spasm of the air tubes. So going out in cold air usually makes people wheezy pretty quickly. And that's very common if you see people go out doing things like skiing and that sort of thing, where the cold air cannot hold moisture, and people get more kind of exposure to cold air. And particularly during exercise, where we're breathing more through our mouth and there's more cold air being passed over the airways, that it's pretty common for people to get a bit wheezy. Indeed, one of the tests that we use to measure whether people have got asthma is to give them a drug called mannitol, and that dries out the air tubes, and most people who've got asthma will get wheezy with that. In terms of what you can do about it, obviously, there's the very sort of practical steps of trying to avoid going out when it's the coldest stages, but often wearing a scarf or a pollution filter or something like that over your mouth while you're exercising really helps. And some of my colleagues back in the UK have done studies looking at people cycling and running with sort of pollution masks or scarves over their faces, and it does have a big benefit on reducing that cold air asthma. The other thing that Sharon says is that she's using a nebulizer morning and night, and again, that's something that we would find as a concerning marker for people's symptoms going forward. So that's something that really does need discussing with an asthma specialist in the hospital, because there is a range of treatments that can be offered that can help people in conjunction with all the normal things that you would do over the winter, including getting your flu shot, your pneumococcal vaccine, making sure that even if it's not a coronavirus season, that you've got good hand hygiene and keeping away from people who may potentially have something that's passable from one person to another. The other thing I was going to mention about the cold air is that that's when people have got bunged up noses as well, and they're not breathing through their nose, that stops the nose heating and humidifying air, and again that makes the cold air effect worse. So there's somebody raising some concerns about kids going to school, and I think that's very understandable. That the children will be exposed to more things when they're going to school than they are normally. They'll be passing around more of the other kinds of viruses that kids pass around when they go back to school, and it does raise the risk of having asthma attacks. There isn't going to be a point where we say it's completely safe to go back to school. It's going to be a case of that risk is slowly going down over time. So it's very hard to give definitive answers to individuals. But I think at the moment, the advice generally is that the number of cases is so low, and if people are abiding by their hand hygiene, social distancing type things, then the risks are pretty low for the general population. Unfortunately, we can't say zero, but pretty low. The other thing to say is as well that the people who have asthma are a very, very tiny increased risk compared to the rest of the population for becoming very unwell with the coronavirus. So they're not at increased risk of coming into hospital in the first instance with the coronavirus, as far as we can tell. But once in hospital, they're at a very small increased risk of becoming quite sick and needing a high dependency area. So that's nowhere near the risk that we might see with some other conditions, and there's certainly nowhere near the risk you might see with being an older individual. So people who are into their 80s are sort of tenfold risk of becoming unwell, rather than just a very sort of tiny 5 or 10% increased risk. The other thing, I guess, on that front about sending kids back to school is that it might be some time before we have an effective virus for this condition. Sorry, effective vaccine for this condition. You may be aware that the novel coronavirus isn't just one thing; it's mutating all the time, and there are thousands of different substrains. It's a bit like colds and flu, so there may be a little time till we are able to offer protection against everybody. And so in the short term, while we don't have an effective virus and we don't have any effective treatments that are being trialed in tablet form or injected form, then those sort of basic measures of care like the distancing, the hand washing, and those sorts of things are things that are really important at the moment. Okay, so those are the sort of key things I was going to cover in terms of the acute asthma treatment and comments around how things have changed with the coronavirus at the moment. I'm happy to go into more details about aspects of that if people are interested in that, or indeed take questions about any other aspect of asthma care. One of the things while we're thinking about asthma attacks, perhaps to mention, is that the use of monoclonal antibody treatments that some of you may be on or you may have heard about, mepolizumab, benralizumab, those kinds of things. These kinds of antibodies, we're using an increasing amount in the clinic. Most clinics will have 50 or 100 people on these drugs now. They are very, very specific to reducing the risk of reducing the number of activated eosinophils, these white blood cells that cause a lot of mischief in asthma. They don't have any effect on your response to the viruses like this. So a couple of people have asked questions about the role of Pheno in relation to asthma management. So Pheno is exhaled nitric oxide. So that's when you have a test which is a little bit like being breathalyzed by the police for alcohol, but we're measuring nitric oxide in your breath. So nitric oxide is associated with this asthma type inflammation in the lungs, and particularly allergy type inflammation as well. So if people have symptoms that are suggestive of asthma, and their nitric oxide is raised, then that gives us a diagnosis of asthma without the need for additional things like spirometry. In people who have uncontrolled asthma and their Pheno is raised, that usually implies that there's the inflammation in the lungs is not adequately treated. So its use in diagnostics is very well established. Its use in monitoring is not quite so well established, in the sense that in certain circumstances it seems to work well, and in others slightly less well. One thing that we do use it for routinely is if people have high nitric oxide and we change their treatment and it comes down in terms of their inhaled treatment, that's usually a marker that we're making progress. And that's sometimes you might have your inhalers changed because inhalers have different particle sizes in them, and sometimes we need to get more drug to the smaller air tubes, and that drops the Pheno level. Also, with the use of smart inhalers now, we can have a look at how many actuations of their inhaler people are using, and we can see how the Pheno level changes with inhaler use. The flip side of that is we can also use Pheno to reassure ourselves that we can reduce people's inhaled steroids. So a lot of people will have asthma, but they won't have raging inflammation in their lungs. And in those people, we can reduce the amount of steroids they're on. So being on inhaled steroids, and particularly some kinds of inhaled steroids, will increase people's risk of having chest infections. So if you're the kind of person whose asthma has a lot of chest infections, and you're also on a lot of inhaled steroids, that's probably making it worse. And so by using things like Pheno, we can monitor that level, bring the steroids level down a little bit to the level which is appropriate but not too much, and then reduce the number of chest infections people have. The other thing that we do a lot of monitoring with now is just a simple full blood count, and we look at those eosinophils in the blood. And if those numbers are high, that's a real good indicator that the asthma is badly controlled, and that we should increase treatment, and particularly increase treatment with these newer medicines that we have. If the numbers are low, that's very reassuring in terms of the asthma type inflammation, and that we can often back off a little bit and still be safe. The one thing I would say about these Pheno recordings, though, is that there are quite a few things that will alter the Pheno level. So, for example, if people have allergic rhinitis and it's very active at the moment, they can often have a very high Pheno level, even if the chest is pretty good. Similarly, can be altered by eating certain things before you do the test. So it's always worth double checking that somebody in the clinic has recorded what you've had to eat, and also had a look at your nose and sinuses before they interpret the result. Okay. So somebody asking about the different kinds of preventative treatments that we have. And so there are quite a number of things to choose from on that front, these different combinations of steroids and long-acting airway opening drugs. And the question is one better than the other? And I would say really it comes down to each individual person to tailor what their needs are. So for example, Brio, that's been mentioned, is a once-a-day drug. So for people who sometimes forget their evening doses, like a lot of people do, that's helpful for those people. However, something like Symbicort has a much faster onset of action. So if you're the sort of person who gets up in the morning and is a bit wheezy, then maybe having something that acts quicker is more important for you. The other thing to say is that the Symbicort is also used as a reliever drug. So that's again quite a helpful strategy for some people, is to use the same inhaler as their preventer and their reliever. You only have to buy one inhaler, you only have to take one round with you. And also on days when you're not quite so good, you're getting your reliever, but you're also getting more preventer mixed in with that. So that can be a very helpful strategy for some people. Whatever you take, it's really important to have somebody go through that inhaler technique with you. So about 8 out of 10 people aren't quite using their inhalers as well as they should in terms of the technique. And also that applies for healthcare professionals as well. So about 8 out of 10 GPs won't quite teach you the right inhaler technique. So I would direct people to the really useful videos that are out there from National Asthma Council and other people like that. So there's the question about the drugs themselves. I think it's also important to think about the way they're delivered, the old-fashioned sprays and the new and sort of newer mists and the powders as well. So different ones are suitable for different people. Younger people tend to breathe in very vigorously, And sometimes that means a lot of drug sticks in the throat. You can't quite get around the corner into your lung. And so sometimes that's not quite so beneficial, and you get more throat side effects. And for other people, they find the dry powder is something that irritates them more. Something you may have seen recently is the amount of so the carbon footprint of these spray inhalers, the pressured metered dose inhalers, the old-fashioned Ventolins and things. So the propellants in them contribute a huge amount to greenhouse effects. I think the really important thing about that point is that you shouldn't stop using an inhaler because you're worried about the environmental effects. And if that's the kind of inhaler that suits you best, it's best to carry on using it. However, if there comes a choice in the future about maybe having a different kind of device and a spray, then your doctor may well factor that into the discussions with you to see whether we can avoid giving giving us quite so many sprays out as we do at the moment. I think that's something that we're probably going to be working on over the next 3 or 4 years to reduce that effect. So I think for most people who have taken their preventative regularly, the difference in switching from a spray to a dry powder is about the same as switching from a normal car to an electric car in terms of the greenhouse gas savings. But obviously that is something that we don't want to interrupt people's treatments, and we want to make sure people are on the right treatments for them. Yeah, so somebody's mentioned that healthcare workers in hospital say something different how to use their inhaler, and that's frustrating. I very much take your point on that front, that people do get given conflicting advice, and I'm sorry that happens. The standard videos from our National Asthma in Australia, and also from people like Asthma UK, they're all standard. I quite like the Asthma UK videos as well. I think they lead you through nicely, and you'll get the same message from those videos. When you start being given sort of tips and tricks and things from local physicians, then sometimes it's not really evidence-based, and best to stick to the sort of the standard guidelines. And if it's not working, then maybe there's the time to change the treatment or revise the treatment rather than just make very small changes to the inhaler technique. So somebody's mentioned about being just recently being diagnosed and it being quite scary and becoming very breathless. I think that sort of raises two issues, that we're aware that a lot of people out there have got a lot of anxiety and concern related to their asthma, and that's very natural. You go from being pretty healthy one day to next day feeling very unwell and perhaps just being rushed into hospital. So in our severe asthma clinic, about 50% of people, half, would meet the criteria for being diagnosed with either anxiety or depression. And that's something I think we all as a community need to help people more with. I think sometimes we get a bit too focused on the inhalers and tablets and things, and not really thinking enough in the round about how people are coping. So yes, it's something you should definitely think about raising with your GP or whomever, to say, well, maybe some psychological support is needed, and it's not a sign of admitting defeat. It's part of having a chronic illness and being unwell. The second thing you raised about being breathless on fairly brief exertion also raises the issue that a lot of people with asthma have asthma and something else, and when those things come along together, that can make people very breathless. So we see a lot of people who've got things like throat problems, like inducible laryngeal obstruction, or little patches of scarring, the bronchiectasis in the lungs. And when both of those things are flaring up at once, that can make people feel pretty unwell and breathless. And also sometimes the reliever inhaler doesn't work so well if it's a mixture of asthma and something else. One of the things that can be helpful across all kinds of breathlessness that people get with asthma is thinking about how people breathe, because sometimes people's breathing gets inefficient when they get breathless. And so there are sort of specialist physios who can help with that kind of breathing retraining. And there's also some online content that can be helpful there. Okay. So I'd like to thank you guys for your questions and comments so far. It's really helpful for us to get a flavour of the kinds of things that concern you, not only because we should think about how we are organising our own services here, but also that we need to be thinking about what our research priorities are going forward as well. It's important that we get a broader feel of what is important to people as possible. So Maggie's mentioned that when your asthma flares up, you get wheezing in your throat. So this comes back to the thing I mentioned earlier on, that a lot of people there have inducible laryngeal obstruction. So when we're talking, our voice box and our vocal cords are moving around to restrict the flow of air and make the sounds. And when we're breathing heavily, those structures should just get out of the way and let us breathe well. In quite a lot of people with asthma, they're getting wheezy down here, the airways are narrowing, but also it's narrow up here as well, as if you're making a sound when you're talking, but all the time. And so it's pretty common that people will start to get restriction of the air coming in and make that kind of noise as they're breathing. And that compounds the problem down in the chest. Unfortunately, the kinds of medicines that we give people to help with their lungs, like Ventolin and Asthmol, they can make this problem a little bit worse in the short term. And so it's sometimes a thing that we need to engage with our speech pathology colleagues to give people exercises, to diagnose it formally in the first place, and then give people exercises to relieve that. That can be a big issue for younger people, particularly younger women, and particularly on exercise. So, for example, for people who are, we do sometimes bring people into exercise on an exercise bike or something like that, whilst also having a look at their throat with a camera, just to make sure we're 100% clear. Is it their asthma or is it a throat that's causing trouble? So, and somebody's mentioned about having blood clots on their lungs, and obviously anything that comes along to injure your lungs that's not the asthma will reduce your ability to get oxygen into the bloodstream and make the asthma feel worse. So I'm sorry to hear that you've had two things on top of each other. That sounds pretty miserable. The asthma itself doesn't raise people's risk of having blood clots, but being on prednisolone tablets does raise your risk of having blood clots. So that's why we try to be quite careful about giving people long-term steroids. So a burst of steroids for 5 days or a week, it's necessary. You should definitely have it, but that's why we get quite concerned when people are on steroids for a longer period of time. Over the last few years, we've become much more aware that being on steroids increases people's risk of things like blood clots and heart attacks and other things like that. So, a burst of steroids is fine, but long-term steroids are bad news, and that's when you really need a specialist review to say, okay, let's get you off the steroids and replace them with something else. Okay. So somebody mentioning having the depression as well with the asthma. And, I'm sorry to hear that's affected you, and it's a common thing that we see in the clinic. It's something that we should be working harder to try and address for a lot of people. The types of medicines that people take for depression don't tend to have any effect on people's asthma, either positive or negative. So if you need that kind of treatment, that's something you should go ahead with without the concern on that front. Thinking about other kinds of treatments that you might take alongside your asthma. Obviously, we do see occasionally people coming to the hospital with an asthma attack because they've taken anti-inflammatory painkillers, ibuprofen, those kinds of things. So if you're ever uncertain about whether you're able to take that, it's worth talking to somebody about it first. For a small minority of people, it does make their asthma quite a lot worse. Similarly, we occasionally get people coming into the hospital who are taking some beta blocker treatments for their heart. So again, if the GP is thinking about starting that kind of thing, ask if are there any alternatives to avoid that. So Hello, Rebecca. You mentioned that you flare-ups, but you have pretty good lung function. So that's not an unusual state of affairs, particularly in people who have been diagnosed a little bit later in life. Not always for people who've been diagnosed very young, but there's a discordance between people's lung function, the amount of inflammation, the number of flare-ups that they have, and sometimes it's worth us sort of unpicking more carefully about what's driving that. Is it this asthma-type inflammation, infection, or is it something else? Because as I say, sometimes people have a bit of scarring on the lungs, or something else that's driving that. It's actually pretty uncommon that we ever see anybody with an immune deficiency. It's usually something else that's causing the problem. So people with asthma pretty uncommonly have a genuine immune deficiency. What they do have often is a reduction in the amount of antibody that you form against certain bacteria. So the test results can appear low, but then when we give people vaccinations and things, they have a good response to it. You mentioned that your asthma got worse with pregnancy, and it's very unpredictable how people will go when they're pregnant. We see about a third of people do get substantially worse, and that's partially driven by the changes in the body in terms of making a little bit more wheezy, but predominantly because there's much more demand on the lungs, because they're having to bring in the oxygen for two people, not just one. And also that having the baby there is pushing up the breathing muscle, the diaphragm, which means you can't breathe quite so well with your breathing muscle, and it's harder work to overcome the narrowed airways. It's actually really uncommon for people to get bad asthma later in pregnancy. So they tend to get better as the pregnancy progresses, and then later after delivery, it tends to get a little bit worse again. I think when people are just generally very run down and not sleep deprived and so on, it tends to have a negative effect. The one important thing is that all of the asthma treatments that we give routinely are far safer than having uncontrolled asthma. So it's really important that if people are pregnant, that they just carry on with their asthma treatments. Nothing should be stopped. And if there are any concerns, talk to the asthma clinic about that. But for the vast majority of people, we would just carry on with the usual treatment. So, so Pauline's asked, how long can you stay on the steroid-based buffer? So that's a good question. The steroids that we talk about, tablet steroids, are in much bigger doses, and they're going through the gut into the whole body, whereas the inhaled steroids are a much smaller dose, and the transfer into the bloodstream is much smaller. So there's no long-term damage from being on a standard dose of asthma inhaler, and so we would strongly encourage people to be on a preventative inhaler lifelong. There are some instances where people are on very high doses of inhaled steroids, and a little bit of steroid will spill into the bloodstream, and then there is the potential for your own body not to make quite enough of its own steroids. And so in those circumstances where people are on a really big dose of inhaled steroid, we would always say never stop them abruptly, because then your body needs a bit of time to get going again with its own steroids. Again, you should normally know if you're in that position. So being on, for example, Seretide or Symbicort or something, but also an additional steroid inhaler, or taking, say, 4 puffs of your inhaler twice a day. If it's on a standard dose, it's not going to be an issue in the long run. Excuse me. Yeah, so thank you for flagging up the Asthma Australia link to the asthma and pregnancy webpage. It can be a challenging situation, and again, as we talked about earlier on, sometimes people can get some unusual advice from people who work in obstetrics, and I think it's important just to double check with a standard organisation and a learned institution like Asthma Australia's pages, and also there's obviously there's a National Asthma Handbook and other kinds of guidelines that people should be following there, and so it's pretty well written down what we should be doing. Great. I'm aware that I've been talking at you now for quite a long time, about 45 minutes. So I think I'm going to wrap this up now. I think I'm very grateful for you to have shared those questions, and I hope it's been of some help to you. To sort of summarize what we've been talking about, I think in the first instance is that everybody's at risk of having asthma attacks, and so everybody with asthma needs to be on some kind of preventative treatment. And that the risk of asthma relates not just to people's symptoms, but also to other things that we can measure, and other things that affect the asthma as well. And we've got to be aware of all those things. That if people do have a worsening of their asthma that needs a course of steroids or antibiotics, it's really important to get more follow-up with your GP or your hospital to say, okay, why did that happen? How can we stop it happening again? Because otherwise you'll just sustain lung damage over time. And then the third thing is, if the worst comes to the worst and you do need to come to hospital, then please do come in, because we're well set up for separating people with not just the novel coronavirus, but all kind of other viruses like flu from people who don't have that. It can be a little bit challenging when people are in hospital and everybody's gowned up, but we're working hard to get people out of that situation as quickly as possible and get them back to normal. In terms of the getting things, shall we say, back to normal with coronavirus, I guess my take-home message would be there's a lot of very good advice out there on government websites and on websites like the Asthma Australia website that we should be following, and that at the moment there's no treatment that will either reduce your risk of getting it, or if you've got it, reduce your risk of getting ill. So the really important thing is to try and stop getting it in the first place, like we were trying to stop getting, other kinds of infections. So keep your hands away from your face, keep washing your hands, and keep that distance away from other people if you can. So thanks very much for your time today. I hope you found that useful. I'm sure that the Asthma Australia team will be very happy to take any other kinds of questions and things through their hotline. They provide an excellent service there. And I look forward to doing something like this in the future. And if anybody's got any suggestions for topics, we'd be very happy to hear from you guys. Okay, thank you very much.